So today I'm just going to talk about the Eastern Health experience of how we've used data to inform the development of a rapid response system, identify opportunities for improvement and evaluate and sustain a rapid response system. So why collect data? We're all collecting data all the time, and sometimes you think, where is this all going? But anyway, we have to remember it is important. And it helps us to understand a problem. It helps us to identify potential solutions, identify opportunities for improvement and assess whether change is occurring. It also helps us evaluate an improvement or a change. So Eastern Health's a large public health service in Melbourne's East. We've got 3 acute sites, Box Hill, Maroondah and Angliss, 2 standalone subacute hospitals, Peter James and Wantirna, and a day hospital at Lilydale and a small district hospital out of Healesville. So in the development of a rapid response system, we needed to use data to establish the baseline or the current state across those sites. So although we were Eastern Health in name, we were actually multiple sites and everybody did things a little bit differently. We needed to understand the problems at each of those sites and identify possible solutions. We used the data to inform and develop a business case, and we needed to engage clinicians, but also we needed to engage decision makers to resource the rapid response system. So our goal was to develop and implement a framework to improve the recognition and response to deteriorating patients. We needed to reduce preventable morbidity and mortality. We needed to comply with the new national standard, so I'm going back to, this was around 2011, and establish a system to evaluate and monitor org-wide performance. So our problems were that we had multiple sites, we had variation in practice, we had no consistent org-wide framework, and we had no common data set for the rapid response system data. So what did we do? We established a standard and then we defined process and outcome measures. We looked at and developed standardised rapid response system documentation, data fields and a database. And then we established a central reporting platform for that rapid response system data. So that enabled clinicians and decision makers to access that data. We developed audit and reporting schedules and we conducted a risk analysis. So this is just an example of a bow tie risk analysis methodology that we use at Eastern Health. And one of my former colleagues introduced us to this, and it was a way of analysing the risk and identifying the causes. So on the left-hand side, you'll see these were the causes of our problem. And then we were able to work with clinicians to identify preventative controls that we needed to put in place to manage the problems. And then we looked at what were the consequences and we built recovery controls. So we were looking at prevention on one arm and mitigation on the other. So we do this for all our aspects of clinical deterioration. It was a great way to actually engage clinicians because it was easily understood and it was a way to work together. So identifying improvement opportunities, we do a risk review like that quarterly and we have data to inform the risk assessment. So then we can review the controls that are in place and decide, are they working? We look at incident review and analysis, we review variations in practice, identify gaps and then consider new research initiatives and the latest evidence that's out there. So just a few examples of improvement work that we've identified needed to be done through our data. So in our standalone subacute hospitals, there are no ALS responders on site. Ambulance Victoria provides ALS response when we require it, and at the start they only had a code blue response for collapse. So when we introduced a rapid response system in subacute, what we did was we decided the decision was, do we introduce another layer and have MET for MET criteria, or do we actually continue with code blue but bring it back for MET criteria? And so that was the decision, to stay with just a code blue, but code blue became for early detection with an aim to actually get those patients moved to an acute site earlier. However, incident analysis showed we had delays and failures to escalate, and when we looked at our staff surveys, they identified that there were barriers to calling a code blue, and they included fear of criticism from colleagues and responders, and also a reluctance to call when the patient didn't look well enough. So as a result, we introduced MET in October 2014. So this is when we implemented the rapid response at the subacute sites, and then we introduced MET. And you can see that we have actually now got a very engaged staff at both those sites, and the calling rate has gone up markedly, particularly at Wantirna. So patients at risk was another thing similar to the Hospital at Night program, that this opportunity was identified through benchmarking data, where it was identified that patients admitted after hours or at weekends were at risk of higher mortality. So a patient at risk team was implemented, and that consists of meetings with nursing coordinator, liaison nurses and the medical registrar at night. And they meet at night about 11 o'clock and then in the morning before handover. So since we've introduced this program, we've seen increased visibility of our patients at risk. We've increased the average number of patient assessments conducted on those patients, increased MET activations overnight, and it's been reported that there's improved communication and teamwork from staff. Sepsis was another problem that we had identified through data, and it was recognised that it was a condition that was contributing to a high incidence of MET calls and patient deterioration. So we had a phased rollout of sepsis pathways based on the Clinical Excellence Commission's Sepsis Kills pathways from 2014 to 2016. And pathways were implemented for paediatrics, neonates and adults. They were also tailored to populations for our satellite dialysis units, hospital in the home and also standalone subacute hospitals. So since we've introduced sepsis pathways, we've actually seen a reduction in our median length of stay at our acute sites, and the mortality rate has improved as well. So with sustaining the rapid response system, we use the risk-based approach to identify the barriers, threats and opportunities to improve. We use data to determine system and practice reliability and resilience to motivate further improvement and ensure patient safety. Some of the data that we look at is we conduct bedside point of care audits, and these are conducted to evaluate compliance with documentation of observations, compliance with monitoring plans, escalation of care, and these reports are available at different levels, so they're able to be drilled down to ward, program, site and directorate levels. Deteriorating patient surveys are conducted across Eastern Health, across all staff, to understand clinicians' attitudes to the rapid response system and identify barriers and enablers to recognition, response and escalation. We also get great ideas from staff through conducting these surveys. Just an example of some of the questions we ask on the surveys. And we also look at the field data like rapid response activation across the sites, MET call rates, cardiac arrest rates, mortality, raw mortality rate, and also HSMRs. And other measures we also monitor are unexpected in-hospital death rates, failed escalation with mortality, risk-adjusted cardiopulmonary arrest rates, compliance audits with resuscitation equipment, and training completion for basic life support and advanced life support. Sharing data we've found really important to continually have clinicians engaged and giving them the feedback to know how well we're doing. So data is available via the Insight reporting platform on the intranet, but it's also shared with clinicians at site clinical deterioration meetings, and the data presentations are then sent to the sepsis champions for each ward so that they can share them with their local teams at ward meetings. Data is also incorporated into education resources, and an annual report's provided to executive and board, and that report's then distributed via the program line. So in conclusion, data is powerful for quality improvement, to identify those areas for improvement, drive change, engage clinicians and decision makers, and evaluate improvement. And we believe that the use of data has contributed to improving patient outcomes and reducing harm in our organisation.